Hello everyone. So today we have again come with one more learning case, which was presented by Dr. Hina, senior resident in our departmental case discussions, and the video recording is done by me. A 35-year-old male patient with history of road traffic accident. He had a skid and fall from a bike, came to our department. He had a complaint of pain and swelling over the posterior aspect of the elbow, along with restriction of movements and inability to lift weights. In orthopedic examination, there was crepitus over the posterior aspect of the elbow with swelling over the elbow joint. The patient was referred from the Department of Orthopedics for radiographs of left elbow joint and ultrasound. There were no previous investigations available with the patient. And the modalities which we did in our department were AP and lateral radiograph of the left elbow, as well as ultrasound. So these were the lateral and the frontal radiographs of the left elbow, where we found that there was an abnormal radio opacity seen over the posterior aspect of the left elbow joint. On closer look, we realized that there was a defect in the olecranon process, and hence the abnormal radio opacity was the avulsed fracture fragment. Retrospectively, when we looked at the AP radiograph or the frontal radiograph, we realized that there was the homogeneous density of the olecranon over the medial aspect was lost, and there was an avulsed fracture fragment. On ultrasound, there was displaced fragment of the tip of the olecranon process with associated hematoma. Also, there was joint effusion in the elbow joint. Now, we also realized that some of the fibers of the triceps muscles were attached to the fractured fragment, while there were few fibers which were going and attaching themselves at their correct position of insertion, overlying that fracture fragment. All the other pertinent points pertaining to the fractured fragment, like the measurement of the fractured fragment, as well as the distance of the fractured fragment from the original bone, were given in our report. So the final diagnosis that was kept was partial avulsion injury of the triceps tendon with displaced fragment of the olecranon process. Coming to the literature review, now the triceps tendon avulsion is one of the rarest tendinous injuries. It has been said that they constitute only 1% of the avulsed fracture fragments. The lateral x-rays of the affected elbow show a small piece of the avulsed fractured osseous fragment, as was seen in our case also, and it is known as the flake sign. And the combination of the palpable depression proximal to the olecranon with loss of active extension, elbow extension, and the flake sign helps to clinch the diagnosis. Now, this is true in case of complete injuries where we get depression, a sizable depression over the posterior aspect of the elbow. There are two types of mechanism of injuries involved. The most common event is the deceleration force imparted to the arm during extension as the triceps muscle is contracting. However, sometimes simple uncoordinated triceps muscle contraction against a flexed elbow can also cause this type of injuries. There are other pertaining medical conditions like hyperparathyroidism or gout, or in case of olecranon bursitis, these injuries are more common. Also, in patients who take steroids into the joints, the injuries of tendons with avulsion are more common. So regarding partial tears, partial triceps disruptions may be more difficult to diagnose, as I already said, because a partial effect may not be palpable and weakness near the extension is not appreciated. A differentiating finding for partial triceps tendon tears, specifically for the medial head, as seen in our case, is the weakness with resistive elbow extension in flexed position. When we flex the elbow at 90 degrees and then try to extend it against resistance, then the patient may not be able to do that. The treatment of choice for active individuals with complete triceps tendon injury is surgical repair. However, in case of partial tears, each case must be individualized with treatment based on the functional strength of the extremity and the patient's general medical status and goals. So accordingly, the orthopedicians keep the patient under conservative care, or maybe they do active surgical repair. So thank you very much for listening to us, and stay tuned as few of my residents say in their video. Thank you very much.